Hi, this is Joe Humphrey, and I'm a primary care internist with special interests in diabetes and health information technology. I've always been a safety net provider and recently stepped down as the medical director for the Lanai Community Health Center. I've been a member of HIMSS for 10 years. And I want to start by describing Lanai Community Health Center. Lanai Community Health Center is a federally qualified health center caring for a little over 2,000 people a year. The federal part of the title means that we get part of our money from the federal government, specifically HRSA. We also have benefited from a number of grants allowing for our healthcare transformation. Lanai is the smallest of the populated islands in Hawaii, with a population of approximately 3,000. This quote is from a recent article by the former Surgeon General, Dr. Jerome Adams. The control of hypertension is getting worse, not better, in the U.S. Poor control of hypertension is not a failure of the provider, but it's a reflection of the fact that the quality of healthcare in the United States is getting worse. The finding in this study is consistent with other population outcome studies of people with chronic conditions. Over the last decade, we have seen major advances in technology and medical science that have not resulted in improved quality or actually show poorer outcomes. There is a burning platform and a delivery system that everyone who contributes to the transformation of healthcare needs to be aware of. I want to share the 30,000-foot view of Lanai Community Health Center. By 2012, multiple comparative studies demonstrated the quality of care in the United States was progressively falling behind other industrialized nations. The policymakers and employers in the U.S. were focused on cost. Besides having the most expensive health care in the world, we also were not obtaining the desired outcomes. Outcome studies in life expectancy, infant mortality rates, rates of chronic conditions resulting in death and disability ranked the U.S. last compared to other industrialized nations. Organizations focused on defining quality metrics such as NCQA and the National Quality Forum primarily focused on process measurements obtained from claims data. Process measurements relate to performance of healthcare providers and hospitals, but do not correlate with patient outcome. Lanai Community Health Center focused on patient outcomes using predictive risk models. We subsequently added quality of life metrics for older patients and patients with disability. Our vision focused on meeting a patient where they wanted to receive their care by a compassionate team that built trust to improve outcomes. Through remote monitoring and restructuring the delivery system, we moved from office care to episodes of home and community-based care to increase quality and access. Patients had the option of sticking with traditional office encounters or to select home and community visits using communication technology. Often there is expectation that technology will lead to transformation of healthcare. Our focus was on improving access and quality by using technology in conjunction with the redesign of our delivery system. Remote monitoring is a component of a much larger transformation of our delivery system and uses technology. This slide shows the evolution from licensing Zoom for telehealth and in the initiation of self-measured blood pressure, SMBP, or home blood pressure monitoring, to the expansion of our telehealth services the introduction of Bluetooth-enabled blood pressure cuffs and glucose meters, and the integration of a disease risk calculator into our information system. Technology is the technical heart of our program. Is our health information applications. Our EHR does what EHRs do best. It replaces the paper chart and supports practice management. Our EHR interfaces with our data warehouse with nightly data dumps. The data warehouse supports population reporting, decision support, and analytics. The data warehouse is designed to export data nightly, populating our care management application with clinical data. The care management system is cloud-based, accepts patient-generated data, including SMBP and self-measured blood glucose, and makes relevant data available to our team, our pharmacy partners, and our patients. This slide lists the element of team-based care. The best way to engage patients is with a compassionate team. Technology does not engage most people in a population, it supports people engagement. Team-based care has repeatedly been shown to improve patient outcomes and cannot be replaced by technology, telehealth, health plan care managers, or disease-specific quality initiatives. If the application does not complement team-based care, the application may disrupt and fragment care for a population, even if it improves outcomes for an individual. Our care team are all in a single room. We use a messaging application, but most communication is team members talking with each other. To a certain degree, we have co-located the team to improve communication rather than using technology. Historically, large health systems could afford telehealth hardware and communication technology. They became the hub supplying the required technology for rural communities. Zoom was affordable and made Lanai Community Health Center a hub, providing the technical infrastructure for our partners, an essential component to developing telehealth for our health center. Federal funding comes with many strings attached. Reporting based on standards is a major burden and essential to receive funding. With few staff with college education, we use paid consultants to report meaningful use, including multiple years of audits and PCMH recognition. HRSA reporting and incentives created care team burnout and consumed resources. Our HRSA annual quality metric, UDS, requires an estimated 180 hours of staff time to report. Federal funding initiatives are often problem-specific: behavioral health integration, opioid crisis, COVID, and most recently hypertension requires reallocation of staff time to these programs' specific initiatives. Innovative technology lives off of venture capital. Lanai Community Health Center, a small health center, lives on the real world. We cannot afford the best EHR or technical infrastructure. Changes in federal funding and payment reform are unknown factors and a risk to our providing quality care. Sustaining our chronic disease management program using remote monitoring is an ongoing challenge after the grant funds run out. Improving health outcomes requires addressing health equity. Health equity is measured by health outcomes. Improved technology leads to improved outcomes, as we've demonstrated through using SMBP. The resources needed for a 70-year-old patient with a sixth grade education with English as a second language, remote monitoring SMBP readings is far greater than a 25-year-old hypertension pregnant female. Equity cannot be measured by equal access to technology. It is measured by health outcomes. A major challenge is to deliver technology that fosters health equity. What is the value of data? SMBP requires 12 to 15 readings obtained over several days, once every 1 to 3 months for most patients, and should be reported episodically. Glucose readings should be collected episodically. Patients are perfectly capable of self-reporting measures out of range. The ability does not need to be built into the analytics. Keep data collection to the metrics that are clinically significant. Synchronous or continuous monitoring is technically available, but the added data would not improve hypertension management. Multiple modality monitoring in the ICU is essential for patients who have exceptionally high risks for adverse events. Obtaining the same data from a healthy 30-year-old with a wearable jacket is essentially no value for significant disease detection, and even with the best AI will lead to alert fatigue. Health information exchange for our small population has become progressively less valuable with our specialists via telehealth. Our providers maintain a comprehensive medical record, order all the labs, and prescribe all the medications. We have an average of 15 hospitalizations a year, not counting pregnancy, allowing for effective care coordination in most cases. Our HIE system does not have universal provider participation. We have access to most hospital records without HIE. Our HIE costs $600 per provider in our practice. The dollars do not add up until the costs go down and the system matures. The Lanai Community Health Center elected not to participate in our state HIE. As the nation transitions to SMBP for most patients with hypertension, there is high value in standardizing data collection for population reporting and research. There is almost no value for a clinician to know blood pressure readings from a year ago, or even to know an individual reading out of the office. Data sets developed by committee result in data overload as committees fail to assess the value of an individual data. SMBP is superior to office blood pressures for the diagnosis and management of hypertension. The better data translates into higher quality as defined by patient outcome. Rather than establishing process measures, quality as measured by patient outcomes requires developing metrics that define quality and a system to capture the data. Patient-generated data is broadly defined as information not captured in the office visit and traditional lab and diagnostic testing. Remote monitoring is a piece of the patient-generated data. Patient-generated data is obtained through surveys, questionnaires, remote monitoring of medication adherence or activity level. The data potentially could include patients' use of social media, grocery purchases, images of meals, and a myriad of yet to be explored sources. Patient-generated outcome measures is evolving to measure patients' outcomes. For procedures such as hip surgery, questionnaires measuring patients' performance and perception pre and post procedures. The data may be linked to activity level through remote monitoring to further assess outcomes. The challenge is not whether remote monitoring is available, but what and how we capture the data, effectively analyze the data to improve health of individuals and provide useful data for population studies. IHE US plays an important and essential role in the health IT interoperability. The related narrow but essential role of IHE is part of the healthcare ecosystem. Decisions related to standards directly impact affordability of technology, rural health, and health equity. Striving for complete integration directly impacts essential integration and clinical outcomes. For rural health, the balance between complete and essential integration impacts the cost and the complexities of the information. Designing interoperability requires an understanding of the needs of and the impact of on the healthcare delivery system and quality. Understanding the systems change to improve quality is essential in establishing technology that works in the new ecosystem. I want to recognize the Lanai Community Health Center's healthcare team for their tremendous contribution in developing the SMBP program, and it's been an honor to present at the Connectathon. Thank you.